You've probably seen her. She walks for miles through villages and city lanes, carrying vaccines, heavy registers, and the weight of a million expectations. She's not a doctor. She's not even technically an employee. So who is she? Today, we're diving into the paradox of the ASHA worker, the woman at the very heart of India's public health system. And look, that's not being dramatic. It's the simple, fundamental truth holding a system that serves over 1 billion people together. This one sentence really sets the stage for everything we're about to explore. Just think about that number for a second. Over 1 million women. We're talking about a massive, unseen army. They are the essential bridge, that final, critical link connecting the formal health system to communities, door to door, village by village. So let's break it down. Who exactly is an ASHA? Well, the role was first created under the National Rural Health Mission. And the original idea? It was actually simple and really powerful. A local woman trusted by her neighbors who would act as a change agent to guide her community toward better health. But, over time, that simple vision, it just grew and grew. Now, the ASHA worker is a health educator, a data collector, she's doing disease surveillance, she's even a social counselor. She became everything the system needed her to be. Everything, that is, except a formally recognized and protected employee. And that right there, that brings us to the heart of the conflict in this story. There is a huge gap between the noble promise of the ASHA program and the incredibly harsh daily reality for the women who are living it. This right here, this is what we call mission creep. On one side, you have the promise, a community health volunteer, a mobilizer. But on the other side, well, the reality is a frontline worker for countless programs buried under a mountain of paperwork and endless data collection. So how do they get paid? Well, that's where one of the biggest problems lies. ASHA workers don't get a salary. They're paid based on performance, a tiny incentive for each task they complete. But this system, it's a trap. Payments are often split across different health programs, they're almost always delayed, and they are completely unpredictable. It creates this constant state of financial stress. And this really gets to the human cost. This isn't just a job. We're talking about invisible gendered labor. Remember, the ASHA worker is also a mother, a caregiver, shouldering all the unpaid domestic work on top of her official duties. The system works not because it's built to last, but because it's built on her personal sacrifice. Okay, so you might be thinking, if the model is so broken, why on earth does it continue? To understand that, we have to take a closer, more analytical look at the policy design behind it all. This is the question, isn't it? Because this isn't just an accident. There are very specific structural reasons that keep this system locked in place, even when the cracks are showing so clearly. Okay, reason number one, it's what experts call a low-cost workforce strategy. From a government perspective, it's brilliant on paper. You get massive health coverage across the entire country for a minimal financial cost because you're using an informal workforce. That means fewer liabilities, like pensions or Social Security. It's efficient, sure, but is it fair? The second reason is all about how we measure success. The system runs on what's called indicator-driven governance. So policymakers look at dashboards with immunization rates, institutional deliveries, and when those numbers go up, they call it a success. But the well-being of the worker, the very person hitting those targets, that rarely even makes it into the equation. And the third piece of the puzzle? It's about where the blame and the credit go. The entire burden of actually getting the work done on the ground, that falls squarely on the ASH worker. But when a policy is a success, the credit is often centralized, celebrated in high-level meetings, leaving the woman on the front line completely invisible. And nothing made this contradiction clearer than the COVID-19 pandemic. All of a sudden, ASHA workers were on the absolute front line. They were contact tracing, they were educating communities, and they were providing care at incredible personal risk. They were called heroes, everyone agreed they were essential, but they still weren't given the status or the protection of formal employees. But look, this isn't just a story about problems, it's also about solutions. We can, and we absolutely must, reimagine the future for these million-plus women. The good news is, there is a clear and actionable path forward. And here it is, 4 concrete steps. First step, professionalize the role. Move from volunteer to a formal cadre with a fixed salary and Social Security. Second, empower them with technology. Use it for instant payments and to cut down on that mountain of paperwork. Third, build real career pathways so this isn't a dead-end job. And finally, and maybe most importantly, ensure their safety and mental well-being. At the end of the day, it all boils down to these three powerful words: recognize their work, regularize their employment, and give them the respect they have more than earned. This is the real call to action. So we'll end with this thought. The evidence is undeniable. ASHA workers didn't just support India's public health system. In so many ways, they built it from the ground up. The question now is, will the system finally turn around and build a sustainable, just future